Just kidding.
Maybe I'll help this.
This is why I said, oh my gosh. I read this one.
No. So there, maybe that'll help. You guys get the advantage of the Bozo hat, which the students here don't even know what the heck we're talking about.
Molly Katie
I'm gonna
came in, her hair shaved.
do the, oh, wait, I turn
Amy
Bozo.
Carroll was in there.
I'm puppy.
Are you
Or
talking to yourself up there, or are we supposed to
Something about bozos and puppies.
I'm a kitty.
Something about us or what? I'm getting over it.
That one, for sure, that one.
all right. All right, so here we go. I'm sorry, for whatever reason, whenever it chooses not to allow us to pull up the PowerPoint slides. I'm not going to waste time. We need to get through this chapter. So the gathering vital signs. Like I said, if you're already taking vital signs, so I know that Ellen is able to do vital signs. I know that Rebecca is able to do vital signs. Probably Aaron, Jacinda. I'm not worried about Cambry or anybody else. No, Amber probably needs to come, right? You don't know how to do vital signs.
So we don't know.
You probably need work on vital signs, right?
Yeah, it's been a minute since I've done them.
Okay.
I've never done it.
Okay. So
I get done tomorrow, you know.
I'm working as a nurse's aide.
okay.
The only one that I've never done is the where you blow it up and.
Let's do it the next Saturday.
What do you, I'll finish it later.
No, you can't. Then it throws the whole schedule off. And anyway, so for the vital sign stuff, for the most part, I'm okay with the people that have already done it. Just I'm trying to work out my thing here. It's driving me nuts. There we go. There. So anyway, moving on. So chapter 13, obtaining vital signs. The 6 vital signs are pulse, blood pressure, respiratory, skin, pulse oximetry, and then pupils. Whenever they're talking about pulse, obviously we're going to talk about the rate and the rate and rhythm of the pulse. So is it normal? Is it abnormal? Some other things that are used to describe pulse is thready. So if you feel a pulse and it just feels real weak, real shallow, it's kind of and typically fast. So you're looking at a thready pulse. You also want to note like an overly bounding pulse. Like you go to feel their pulse and it just knocks your fingers off the wrist. That would be a bounding pulse. A normal pulse is you reach down, feel it, 60 beats per minute, normal rate. You don't feel any skips or anything like that. It feels like it's regular. With blood pressure, whenever you take a blood pressure, your top number is your systolic. So we looked that up the other day, and that's whenever the ventricles are slamming shut, and that gives you your systolic blood pressure. That's the top number. So whenever you're doing a blood pressure, I like to go up to like 180, and if I don't hear it, I'll start coming down. There's actually a different way to do it in the book, I believe, and that is yeah, pump it up till you don't hear it no more, go up, and then come back down. To me, Ellen wanted me to be stressed. Pump it up till you don't hear it, add 30, and then come down.
It's on the test. Like, wants to know that number.
Okay. So make sure for the test you know that. Wait, are we live? Okay, we are. All right.
We were at one moment. We were.
Making sure we're live. Don't talk about anybody. So and then Who's that?
I don't know.
Oh, okay.
You didn't leave.
The Muslims.
You enjoyed it.
He's looking
I
away.
just get the radio.
He didn't even hear it either.
Your wife decided she didn't want to listen to me tonight. She just shut down.
Did she?
Yeah. I'm going over her vital signs. She's like, yeah.
I got my butt chewed over something my dogs did, so she's probably thinking that I'm best.
She's happy.
So
No.
No wonder he come back.
Yeah, he's like, I'm not going now.
as you go down after you pump it up till you can't hear, which personally me, I have a problem with that. Whenever I'm taking blood pressure, a lot of times I need a blood pressure right now. And I feel like that takes time to put the blood pressure, no, that's the thing, that my stethoscope on it and listen as it goes up. You also have a lot of artifact with moving, with pumping it up. So that's how the book says to do it. You guys have to know that. But the problem I have is it takes time. It's hard to hear it like that. I go up at 180. If I still hear it at 180, I'll go up to 200. If I hear it at 200, I'll go to 220. And I'll keep doing that until I don't hear it. Then I'll start coming down. As you come down, and that first number that you hear, that first thunk, is going to be your systolic number. And you continue coming down until it goes away. Once the noise goes away, that's your diastolic number. Something that we talked about in lab on Saturday was that whenever a physician learns how to do a blood pressure, they actually have three numbers. They have systolic and diastolic, where it's muffled, and then when it disappears. When it's muffled is actually your diastolic number. Whenever you hear it come down like boom, 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 boom. Once you start hearing that muffling, that's your actual diastolic number. Us in EMS and nursing and everything else, we do it whenever it disappears. That's how you guys need to do it for here. But understand, there are times where you'll hear it all the way down to zero. It's okay. All right. If that's the case and you want to get an accurate systolic diastolic number, go back up, get your systolic number, get your diastolic number when it goes muffled. Once it muffles, that's what your diastolic number is. So I hope that makes sense.
Which is supposed to wait like a minute in between.
Or switch arms.
Okay.
So respiratory, rate, rhythm, and you want to talk about depth. So on your respirations, what's the rate like? What's the rhythm like? A normal person breathes at 12 to 20 breaths per minute.
That's very important.
Once you get over 24, they're considering that to be acute, a serious patient. I agree. That's kind of iffy. That number's kind of, to me, it's not that big of a deal. 24 breaths per minute is not that big of a deal. But understand, for this class, you get somebody with a respiratory rate over 28 beats per minute and confusion, you're probably going to assist their ventilations, all right? Or at least get them some oxygen, but most likely the correct answer is going to be assist their ventilation. Because what you're going to do is make sure they get plenty of volume. Under 10 breaths per minute, is that what they're saying in the text? Under 10 is a
12 to 20 minute at rest.
okay. It should be in there
Yeah,
where
it's under 10 and over.
Under 10 and above 24
Okay.
is zero.
there it is. Yep, serious. Like there it is. Above 24 is serious and below 10 is serious. Guys, I'm just going to be completely honest with you. You're going to have those patients that are breathing 8 to 10 times a minute. It's normal for them. They're in really good shape. Yeah, and they're comfortable. Really good shape and comfortable. Don't freak out about it. Go with everything else. Treat the patient, not the the range. Now, if it's under 10 a minute and they're hypoxic, they're tired of breathing, you guys have to assist those ventilations. Understand, for any testing purposes, if they give you somebody that's under 10 breaths per minute, they're probably also going to give you something else to go along with it, like they're confused. All right. Yeah, and mental status change is a big one that they like to do. So if you have a mental status change and it's either below or above that number, know that it's a serious issue. But you could also find other things from respirations, and I'm not sure if they went through it in here or not. But let's say that their breathing is sporadic or erratic. A lot of times that's caused by a head injury. So you see them breathe, they start breathing. They call it Shane Stokes respiration. So it's crescendo, decrescendo. So it goes up, the respiration get faster, 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 deeper, 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 and all of a sudden it starts coming down, and then it's absent. Then it does that, goes up and down. That's very indicative of a head injury. So if you see somebody breathing like that, they've been in an accident, fallen, anything like that, no, that's probably from the head injury, and they're not in a good place. So you have some different things you could tell from respirations. They go over that in your text. Anybody that's read it?
Talk about crowing.
Crowing.
Medical problems that cannot be treated on the scene, off transport.
Huh.
So now they're calling it crowing. Yeah. So wheezing, snoring, and crowing.
You know, I believe that their crowing is a
noisy, harsh sound of breathing in.
yeah. I was gonna do it for you, but since you're saying it, I won't.
What does it sound like?
Yeah,
Yeah, they need help.
they do.
Sounds like
Typically, you have something like that from some swelling and mucus in the airway. And so, anyway, moving on. Skin, warm, pink, and dry is normal, right? Or warm, normal color, and dry is normal. Oh, hey, Rebecca's back. Did you get the dog mess cleaned up?
Did you hear about that?
Tyler.
There's this guy named Tyler. And did you know Tyler converted?
Well,
Did you know he's a Muslim now?
Every once in a while, I text people.
Oh, well, so you're worried you text me and chewed me out?
Oh.
Yeah.
That's funny. No, I came in. I said, your wife must have got sick of listening to me. She's gone. And he said, no. He goes, it might have something to do with my dog made a mess. I don't know. And I was like,
No, it really wasn't that. I had to go pick up kids, and I have kind of spotty cell phone
oh, okay.
or internet stuff, and sometimes it just drops you randomly.
Okay, not a problem. I'm just going over different things you might see in some of these vital signs. So you don't need to come to the lab on Saturday. Everybody's trying to talk me out of having a lab on Saturday, so we'll kind of see. We'll see where we get tonight. That's what I was gonna say. We might be able to squeeze it all in third. You say no?
You need like 5 days for chapter 14.
I don't need 5 days for chapter 14.
It even tells you in the audio that it's the longest chapter in the book, over 104 pages.
It's the easiest chapter in the book. It's easy. Easy peasy mac and cheesy.
It really wasn't as bad as I thought it
On
was.
Saturday, we have to be through 16.
God, okay. I was very proud of you guys up until today, and then all I hear is whining.
No, I'm saying let's do the last night.
Oh, you want to do lab tonight? So you want to hit chapter 13 and 9, and then do the lab. Well, poor Emilio, he wouldn't be.
I will be going through there on Saturday. I can stop
You
by
can
for
just
20
show
minutes, we can do it. I'll let you know how you done.
I'm gonna buy me a stethoscope and stuff in town Saturday so I can practice on all the people at home.
So you guys want to do 13 and 9, do the lab with the people that are here, so everybody else can go home tonight. After.
Let's just get done with chapter 13 first and then discuss it.
Well, 13, we're already almost done with it.
13.
I'm not. Listen.
I was trying to help you,
Vocabulary
Rob.
refill go away on adults.
I was trying to help you.
Okay, so you're trying to help me, and when did capillary refill go in? Adults? Capillary refill is still used. It's just not used like it used to be because it's very interactive.
Because of the cold.
Yeah, well, and all kinds of things. So you get somebody that. Yes, it's good to see Shot in Rob. Well, you somebody else, somebody that is healthy. they've been in an accident, you check cap refill. Okay, now we have a cold car wreck, and it's cold outside. Now all of a sudden we have delayed cap refill. Now we're calling it a shock patient when no other signs and symptoms support that. A lot of people still use it, and I'm surprised they're not still teaching it in the book. Are they not?
They're like, infants and children under 6 years of age should also evaluate capillary.
Okay.
So, I mean, in the little ones, yes, but in the older people, they still say stuff about it, but they're not really pushing it like it used to be.
Okay.
It doesn't work very well when you have acrylic over your fingernails.
No, you can't see, but you can. I mean, you could do the cap refill anywhere. I mean, you don't have to do it on a fingernail. If you see my finger, I have pink there. I squeeze it, it blanches, and it comes back. The problem with cap refill is how inaccurate it can be. So you have all kinds of different things. And for anybody that don't know what we're talking about, what capillary refill is you take like a thumb and you look at the nail bed and it's pink. If you grab your thumb and you take it away, it's white. If that color comes back within 2 seconds, you have your cap refill is less than 2 seconds. It's considered that you have good circulation. But let's use somebody that it's cold outside. Well, now we have a delayed cap refill. And we have EMTs that really relied on cap refill heavily. Cap refill, oh my gosh, it took it 4 seconds. That is terrible. Well, we need to, and really it's just cold outside. And so they found that it really wasn't as accurate in adults as it is, the younger kids. They have better circulation anyway. I mean, you might have decreased circulation just because of your age. So you have the old people and things like that.
So you say,
You guys, yes.
calling us being cold make me think.
One of the questions was about being cold. The lady was out in the field and she was cold and you couldn't do it. So what was the answer to that? Do you do the ear? Because it told
No, because your ears are cold. If it's cold, you don't do the
On-
ear.
or
On pulse oximetry,
it was on this one over the capillary refill, and it says that
Maybe your
she
toe
had
would be
been, like,
warm.
injured. Not just, my toes are always cold.
They're cold to you.
I'd have to see the question for sure.
It said something about
Can you
this.
not say that?
It's an older lady and it says in the book, you don't want to do capillary
No.
refill on older people anyway.
Yeah.
But that was the thing, it was an older lady and she was outside and her fingers were cold, so you couldn't do the capillary refill. So do you do the ear, the toe?
It said just the little pulse ox thing,
Yeah.
but in that
There's
answer,
a
it
reason for
said,
it.
Exactly.
in that answer, it said try to warm hands and use.
Yeah,
That's what I put, was kind of warm hands.
Can you not check your answers now?
Is it-
Can you not check your answers?
chapter test.
My chapter test opened up the other day.
I
I can check the answers.
Oh, did you open them up?
No.
Mine did the other day where it says review test and all that stuff down there. I hit the review test and it threw all the questions up there, and then I clicked on the top where it drops them, and it gave all the answers.
On your chapter test?
Yes,
Mine's always been that.
not all mine have it on all of them.
Well, the ones that I had,
It's nothing on the post test and the pre-test. but on
Yeah,
the
but they're on the
test.
Mine started doing it the other day on chapter test.
You
I thought
can
Rob
change
did
your
something.
answer though.
Yeah,
Well,
you can't change the answer, but
I
you can see.
asked him to, but he said.
I was wondering what it was.
We're still with you.
I'm just letting you guys go. So, all right.
Hey, I was talking about what you was talking about.
I know. No,
It's class related.
I'm listening. If it
What
wa-
about the pupils, Ron? How do you feel about pupils?
I love pupils. I'm almost there. You can tell a lot from the pupils. Respiratory rate, guys, I'm going to be completely honest with you. I have seen very few people, even when herniating, that the respirations change to a point where it's completely obvious. I know that it's going to say in the text that you will see respiratory rate in these, but most of the time you're going to see on your patients on difficulty breathing, you're going to see a rapid rate, or on your opiate overdose, you're going to see a shallow rate. One of the first things I do, bringing in the pupils, whenever I come to somebody that has a depressed respiratory rate, is I check the pupils. If the pupils are pinpoint, I'm giving them Narcan because chances are they've overdosed. Even those ones that have no drug history and aren't prescribed anything, It's amazing how many of them Narcan brings out of that. Oh, no drug history. Huh? So, and so anyway, skin, warm, pink, and dry. Obviously, whenever you start having issues, let's say like shock, start vasoconstricting, it's shunting the blood to the much needed organs, so that causes that pale color in the skin. And then pupils, like I said, I love pupils. You can tell a lot from pupils. If they're sluggish, pupils, they could be having a stroke, so they're a little bit hypoxic in the brain. But you have some of the telltale signs. You get somebody that has stroke-like symptoms, and you have a blown pupil and a constricted pupil. Most likely they've had a bleed and they're herniating, and sometimes it happens very fast. They will probably say in the book that that's a late sign. But I've been called to an assisted living before where the guy had fallen. Then they took him, they had him evaluated. He got some stitches in the head. They sent him home. We get called, and I check his blood sugar. His blood sugar is right at normal. It's like 79 or I don't remember what sign or one of this to make sure it was, but it was just right under that normal range. I believe it was Signer. It was below 80. You're given dextrose. Thing was, I held off on the dextrose because the guy had just fallen the night before, and when I looked at his pupils, he had a blown and a constricted pupil, and I was like, oh, this guy's herniating. And so we take him in the hospital. Sure enough, he didn't just have one bleed. He was bleeding in 3 different areas of the brain. The family, of course, wanted everything done for him. He was an older man, 89 or 90. And yes, they wanted him taken to the city, but there was nothing that could be done for him. And so you get that car wreck or something like that, real bad. You open up their pupils, and all of a sudden you see a constricted and blown pupil. They have some swelling on the brains pushing onto the midbrain or the spinal cord. Sorry, the brainstem. I'm trying to get my regions right. Push on that brainstem, and what it does is it'll start to blow one pupil, one will be constricted, and you'll know that they're herniating, which basically the brain's pushing out of the big hole in the bottom of the skull. You got to get them somewhere fast. They need that pressure relief. Most of them don't make it, but they have. So don't just give up on them. Get the helicopter there. Pulse oximetry is one of the things I hate the most because I feel like people don't stop and think about what they're looking at on pulse oximetry. I think I've already told you guys, it's a pet peeve of mine that people freak out because somebody has a pulse ox of 70 and the patient's warm, pink, and dry and talking to them. No, you don't have a pulse ox of 70. Either you have poor circulation where you're checking, and one of the ways that you could check to make sure that your pulse ox is right is compare their pulse with the pulse that's on the pulse ox. That reads on there. It'll pick up a pulse. If those two are very close to each other, there's a good chance the pulse oximetry is right. But the other side of that is, does it make sense? Does this patient with 100% O2 sat who has altered LOC, does it make sense that they would be saturating at 100%? The book tells you about CO poisoning. I think I've mentioned that to you guys before, that the carbon monoxide attaches to the hemoglobin. I did read through the book a little bit today. I had a little time that I kind of glanced through it and read a few things. And it said that hemoglobin, whenever that carbon monoxide attaches to that hemoglobin, actually creates the red color that the pulse oximetry is looking for, that shows a bound hemoglobin of oxygen. And so it reads it the same way as it reads oxygen. So you also will have this with your firefighters that are fighting fires that get into a whole bunch of smoke. They come out, they're short of breath, yet their pulse ox says 100%. Try to convince them guys to not go in. You have to use a oximeter that reads methemoglobin. Completely different animal. I don't know enough to talk intelligently about it, but you do have to have it to differentiate if it's CO or if it's oxygen. And so a lot of firefighter rehab services will actually have a methemoglobin monitor. And so they're able to say, no, your methemoglobin's high. So you need to, not go back into the fire. Same thing with your smokers. You have a false high with smokers that are currently smoking because I read that it's 10 to 15% of that hemoglobin is attached to the CO. So wow, that's a pretty high number. You guys walk around with CO poisoning all the time. To my smokers out there,
That's why we need a smoke break. 'Cause we gotta get it,
you gotta get that, yeah.
we gotta get it going again.
And so anyway, I just have a lot of issues with pulse oximetry. I think it's a great tool, but you have to know how to use your tool. You have to know when that tool might not be right and how to troubleshoot that.
Be smarter than you.
Be smarter than tool, exactly. And you guys all in this class, I'm really happy with this class. I think probably everybody in here is a fairly intelligent person, and so I've had classes where I've questioned that. So
Everybody, you said that's smart.
that's all right. You can tell like I said, I'm impressed with this class. So I feel comfortable telling you guys until I catch you telling me that this person's has a pulse ox of 78%, so they need to be intubated, and they're talking to me, and then I'm gonna say, I told you, treat the thing with hair, not the monitor. So anyway, moving on. Something they don't have in here that you guys will need to know how to read as EMT basics is you'll need to know how to read waveform capnography. So you'll need to know how to apply it, which I showed you in class. Most of them are just a nasal, go on just like a nasal cannula. Some of them go on the end of an ET tube. That number you're looking for is between 35 and 45. If it's below that and they're breathing fast, you need to get them to slow their breathing down so it brings that pulse ox up. If it's above that and they're not breathing fast enough, they're unconscious or whatever, you need to assist those ventilations to get it down to that 35 to 45. You start to worry about it whenever somebody's breathing fast and their end-tidal CO2 is high. It's 50, 60, and they're breathing fast. We have a serious problem going on here because typically we think breathing fast, you're blowing off that CO2 faster than you should, so it should be a low number. Okay. Once you guys get your head, and I don't expect you to walk out of this class with your head wrapped around it. It took me a long time thinking about it and how it affected people to understand waveform capnography. And so I don't expect you guys to grasp it. You might, and I hope you do. But know that the range is 35 to 45. You'll need to know how to read it, and you'll need to know how to adjust it. You'll need to know that if it's low, you need to slow your bagging down. If it's high, you need to speed your bagging up. All right. They also go with the skin. They go with skin temp. EMS, I feel like, can learn a lesson from nurses. Nurses love temperature. They love taking a temp, and they do. They're very good at it. As a paramedic taking patients in, nurses always want to know what you get on a temp drive. I don't know. And they feel, well, they're okay. I can't tell they're hot, but they have a temp of 99.4, Rob. Okay, whatever. Not quite that bad, but yeah. But you can tell a lot by temp, and sometimes, like Ellen just did, it's simply if you just feel their skin and they're cooking, they probably have an infection going on. So let's say that we're dealing with respiratory distress. There's a good chance that we're dealing with either a sepsis, so they got a UTI and they become septic, which is common, or let's say that maybe they've been coughing, hacking, gagging, this yellow phlegm up. There's a good chance they have a respiratory tract infection. And so we could use that as a differential diagnosis. So we know that CHF typically doesn't cause somebody to have a fever. It causes them to have high blood pressure, but not a fever. So you could say you're kind of on the border. Boy, their lung sound wet. Oh, I feel the head. Oh, they're running a fever. We could be dealing with some pneumonia here. And so you can start to use that as a differential diagnosis, if that makes sense.
Should you read what they said at your monitors? They're pieces of crap.
Which ones?
Any of them except for the oral one, for the rectum.
Oh, yeah. And I'm not going to disagree with them. You're
Are not accurate enough for EMS use.
oh bullshit. I know that's what they say, but come on now.
Oh, here's another one, are not accurate, yeah.
I tell you what, if EMS knew how to use equipment, then I would say okay. But the problem is you got a lot of EMTs that just tear shit up, and that's what they do. Hey, there's a monitor.
They don't recommend glass either because of the bumpy roads.
So the best way to take a temperature is to drop one of those esophageal orbitrate or whatever. So you drop a temperature probe down into their stomach to take.
The
Yeah, it's a-
rectal temp is the most correct temp that you will ever get.
And Ellen says that
A
you.
core temp.
Ellen says you should stick a thermometer up all your patients' butts because she wants a good. I'm okay. I'll just lay it out there like this to finish this conversation off.
Is that gonna be part of our lab too?
Yes, on Ellen,
On Ellen.
since she likes it.
I sit in the rear.
If EMS was treating temperature related illnesses, I could see being very concerned about a 0.5 degree range that you're probably gonna be dealing with. Maybe a 1 to 2 degree range. I don't know. It's
It says in general, a healthy normal person will have a temperature greater than 96 and less than 100.
How do we get all the way
And-
on temperature?
because I was
I
given the nurses props because they love taking temperatures and
I've kissed foreheads too.
but so the moral of the story is we need to get better at least feeling the skin, to feeling if it's warm or cold, and a thermometer, whether accurate enough or not for the text. For me, it comes down to having equipment that I don't have to worry that I'm contaminating multiple patients. And once you get to know EMTs, you'll know why I'm concerned about that. Oh, we don't have a probe cover, or I can't find it. Here, open your mouth. Okay, I gotta, Ellen looks
That
disgusted.
drives me absolutely
Okay.
nuts.
Back to chapter infection control.
Yeah, no, exactly. And so I like to utilize disposable equipment or equipment that we're not invasive with, like a temp probe. And so for me, what I need to know for that patient, for me to treat them, the junkie does not accurate enough for the textbook is accurate enough for Rob. Anyway, so we talked about respiratory rate, quality, and rhythm. We talked about skin, pupils. So here, skin, they're very vague on it. But one thing I do want to tell you guys, on your normal respiratory rate, you want to know your ranges. You will want to know those ranges, I promise. On your blood pressures, you'll want to know those ranges. And on your pulse rates, you'll want to know those ranges, okay?
And if you really, really, really need to know that 80 plus 2 times age.
Yes.
That's on that test, like
To
47 times.
determine a systolic,
What do you think is 82?
I don't know, that's,
I know.
Is it
80
the-
plus 2 is
Well, it's 80 plus
2.
2 times the age of the child.
we're talking about blood pressure, right?
Oh, okay.
Yeah.
Oh, okay, 80 plus 2 is 82. What do you mean?
So-
Okay.
So 80 plus 2 times their age. So
So 4 would be 80 plus 8.
yes. So your systolic, your normal systolic would be 88 for a 4-year-old. And that's a formula you will want to know. It's pretty common in the EMS world. So, oh, hey, there it is on blood pressure. Infant and children, approximately 80 plus 2 times the age in years. We'll give you your normal. Diastolic, approximately 2/3 of systolic. You'll want to have a good idea of what your normal ranges are on each one. You have to be able to say sphygmomanometer correctly. Just kidding. I can never say anything. I tried reading there. Look like the clue guy.
Sphygmo.
Blood pressure.
Sphygmomanometer.
Oh,
Blood pressure cuff. On your children under 3 years of age, you're really not concerned about getting the blood pressure on. So I believe whenever we go through the pediatric patients, they'll talk about more of a pediatric assessment tool you do. Basically, one of the first things you want to do when you walk in and see a kid under 3 is you want to stay as far away from them as you can, because once you start approaching them, they freak out, and observe their actions. You want to, are they playing, talking, whatever it is, or are they laying on the floor, not really moving or whatever. And so you want to determine that, and they'll talk about that more when we get into the pediatrics. So determining blood pressure, position the cuff and find the radial pulse. Inflate the cuff and obtain and record the systolic pressure. We already kind of talked about how to do systolic and diastolic. I'm just kind of going through here, seeing what else. I kind of beat the oxygen saturation and death.
On the test, you need to know important parts about where that cuff is.
Okay.
Yeah.
So on the test, they want you to know how to or where the cuff goes. Apply the cuff as described for auscultation. Okay, wait, let's go.
Cuffs should cover 2/3 of the upper arm, elbow to shoulder.
You know what? That's another good point. There's also an index line on a cuff. One thing that EMTs and even nurses are notorious is using one cuff on every single patient that walks in. And there's an index line on that. If there's a little bitty old lady, little bitty twig arms, and you wrap it around past that index line, the cuff is too big. You need to go down a size. If you get some guy that's huge and the cuff doesn't go into the index line, you need to go up a cuff size. And that's fairly important. You want to, on your manual blood pressures, you'll want to go ahead and place it so there should be an arrow that points to the.
He was saying that the bladder, that needs to be in the middle of the bladder or something.
Those arrows.
Isn't always right. Didn't it say that?
Yeah.
Something like that.
Screw them, and their arrows are not always right.
The
Stick.
bladder must be placed over the brachial artery, the major artery of the arm. The marker on the cuff, if provided, should indicate where you place the cuff in relation to the artery.
Don't
However,
you probably know this stuff?
many cuffs do not have markers
Do what?
in the correct
Don't you
location.
probably all know this?
Yeah, no, that's awesome. You guys know that. So I don't care.
Just get you some numbers. They're very close.
I'm gonna start looking at that bladder and seeing if it's right or not.
You know, okay, so I think they're over exaggerating here, because most of your bladders, where the hose comes out, it can't move that far. And even if it moves over, once you start to air it up, it's going to, that bladder, like anything else, is going to then fill the cuff. And so I think they're making things a little scarier than they need to.
I'm gonna start measuring my bladders and my cuffs and see.
Yeah. The important thing is you make sure you stay in the index line. Make sure that you don't use too big or too small of a cuff. Make sure that you get the arrow onto where the brachial artery will run up, which is we'd call it the antecubital. AC area is where that's going to point. Whenever we do the lab night, you people understand. The other people that are already doing blood pressure and stuff, they know what I'm talking about. Whenever Jacqueline was going through pharmacy school and they had to learn how to do blood pressure, they actually got certified in blood pressures. And oh my gosh, I was like, you got to be kidding me. That's how they're very picky on how to take a blood pressure. Once again, If I wasn't bumping down a road and I could actually trend blood pressures, I would be a little more concerned about it. I do think it's important to be able to take a fairly accurate blood pressure. Don't get me wrong. But I think that they're trying to make it scarier than it needs to be. So there's two different ways. One by auscultation. So you put the blood pressure cuff on, you pump it up till it goes away, plus 30, come down. You're using a stethoscope to listen. There's another way to do it, which is by palpation. Let's say that you're bumping around on an ambulance, you can't hear. You forgot your stethoscope. You shouldn't have. What you can do is feel for the radial pulse and pump it up until the radial pulse is gone, plus 30. Is that what it's going to tell you to do? I don't know. Just making that shit up.
Oh, yeah, it does too. Make certain the adjustable valve is closed and bolt inflate cuff to the point where you no longer feel the radial pulse. At this point on the gauge and continue to inflate the cuff 30.
So-
HG on this point.
So they just confirmed it is plus 30 on the palp too. And so you're going to keep your finger on the radial pulse, pump it up till the radial pulse goes away, add 30, and then you'll start coming down. Once you feel that pulse hit, that is your systolic blood pressure, and you document it 126 over palp or over P or by palp. And that is, you cannot get sorry, as your systolic, you can't get a diastolic number by palp. So
Why do you go 30 more on that one?
I guess it'd be the same thing as a listening. I think what they're doing is wanting you to go above where it really stops and then come back down to hit it. 30 sounds like that's a lot, because have you ever had your blood pressure taken? That hurts.
Yeah.
And then you get somebody, especially somebody new, that drops it down real slow. And your hands go, your fingers go numb, your arm goes numb. We'll just do it on a mannequin. Because here's a reason no. Because then you guys are gonna say, oh, I got 120 over 80.
My blood pressure runs low.
I got 90 over over 40 because Jay's blood pressure runs low. My dummy, I could set it. And so as you come down, you're like, I got 90 over 40. I'm like, no, you didn't. You need to try again.
No, you didn't.
Nuh-uh. I typically, if you get within a few points, I'm good with it. Oh, I got a birthday cake.
You practice on each other.
In the old days, they had the two stethoscopes or the two listening devices, and the teacher.
Yeah, they had the stethoscope with, yeah, with the split in it. Yeah. I actually wish I had some of those. I'm playing with the Google Effects, which are going away, by the way. So we all need to play with them for so long. So anyway, let's do some.
Finger sticks.
What does it say about finger sticks?
Blood glucose meters.
There was important stuff in there
Some
about which ones you use, because you never know if the patient's is up to date or coded just right.
Gotcha. So, and some other things, and I'm not sure if they go over this or not on the blood glucose. Don't milk the finger. Okay, that's a real common thing to do, but don't milk it.
Wipe it.
Yeah, you want to wipe it, allow it to dry, and then whenever the blood spot comes up, you want to then use your
Wipe it first.
Yeah, you get
Oh,
rid of the
man.
first one.
wipe the first one. I'm not going to get a very good blood sugar anymore.
Squeeze the patient's finger.
Don't milk it.
Don't milk it. Well, I don't know about squeezing it too much unless they're.
Milking, it's where you push the blood down.
You're gonna get all the.
Squeezing, it's where you just kind of squeeze the
I
blood.
think we
You
should test each other's blood.
guys
I
can't-
used to do mine 7 times a day when I was gestational diabetic.
I almost brought my.
Trigger.
Like-
I'm good.
Yeah, like Amber said, you want to make sure you use your glucometer, not the patient's. You don't know how long that patient's been using that glucometer. You don't know whether the strips are in date. whether they have the right coated machine. Some other things, you want to use a finger that is on their non-dominant hand, so a finger they're not using a lot, and like the ring finger that they don't use, so it's not a real callous finger. Sometimes you're gonna get those guys that work outside in solvents and stuff all day long, and their fingers
On
are,
the side.
yeah, their fingers are like leather. You can do it on the side. Ellen says you can do it on the earlobe.
My dad has one, and he can do it on his arm.
They do have, that's a new, not new, like 5 years, it's in the last 5 years. The glucometer that could read it off the arm. Oh, here's the steps right here. Prepare the blood glucose meter, including a test strip and lancet. Cleanse the skin with alcohol preparation. Allow the alcohol to dry before performing the finger stick. Use the lancet to perform the finger stick. Wipe away the first drop of blood that appears. Squeeze the finger if necessary to get the second drop of blood. Apply the blood to the test strip. This may be done by holding the strip next to the finger to draw the blood into the strip. Read the blood glucose level display on the glucose meter.
These meters are so easy, they just almost.
Suck it in. The glucometer.
They're wonderful.
It may take 15 to 60 seconds for the device to provide a reading. Assess the puncture site and apply direct pressure or a bandage to the site if bleeding continues. I just take the alcohol prep and I put it on there and hold pressure and say, hey, grab that, and let them hold it. I'm not going to sit there and hold it. That's just me. But
He's so not a nurse.
what's that?
You're so not a nurse.
I know, right?
And you say.
The nurses get Band-Aids and with little Superman on it and stuff for you, so you feel special. Actually, probably get Band-Aids that say, I love a nurse. Nurses are great or something on. Right, Ellen?
Yeah.
Rob needs a t-shirt for Nurses Week.
Oh, no, I
It says,
don't.
I love nurses.
He does love nurses.
I
He
sure,
needs a t-shirt that says it.
I sure do.
A pink one.
I have a good working relationship with most all nurses. There's one that don't like me very much, but that's okay. So.
Those ones.
All right. So, guys, all I can tell you about 13 is read it and know those.
Just read it.
Yeah, know those numbers. You have to. This is one of the few things you have to memorize is the numbers. It's not something that I can sit up here and drill into your head. It's something that you guys have to memorize. And I promise, the quicker you do it, the easier your life will be, because you'll also get it on your National Registry test. So, Emilio, what you and I will do is at our next lab, we'll just, at the end of it, we'll just go over taking blood pressures and things like that. I'll probably still have class on Saturday, but I know because how it falls, a lot of people are doing things. I'm okay if you can't make it. I will open up the Google Hangouts I'll obviously open the Google Hangouts, but I'll open up the YouTube video. The YouTube video will be available if you want to. It is over, if it gets to 16, even if it's 14, 15, and 16, 16 is pharmacology, but 15 is over report writing. I have some very strong opinions over report writing, and it does fall in line a lot with what the book has to say. So I feel like my tips will be helpful for you in actually writing a report. But that's kind of where we're at. I'll try to get through at least chapter 16 on Saturday. I'm going to do class, but if you have something else going on, Zoo, please go. Please, okay. You have watching cartoons in your pajamas. Stay home, watch cartoons in your pajamas. I'm telling you, I really don't care. But we will go ahead and do the blood pressure, or we'll do the vitals lab tonight for the few people that need it. And then Emilio, I'll catch up with you. Does anybody have any objections to that?
You just want me to stick around after class Saturday and do it, or?
Man, you don't even have to. I wouldn't make it. I wouldn't make a trip over here Saturday for it. Just at our next lab, we'll do it.
Okay.
So, yeah, please don't make a trip over here just for that, because you'd be the only one. So I'm being very flexible in this since it's 2 Saturdays in a row. All right. So I'm gonna stop the Google Hangouts. I'm gonna release the people here that don't need vital signs. I'm gonna keep the few that do, and we're gonna work on vital signs. Does anybody have any questions before we end it?
No.
Did you guys get to see all my Google effects? Did you get to see my halo, my sunglasses?
Yeah.
Good deal. Try to shut them off. Since you guys had a look at me tonight, we got to do something different. Turn my face off. Turn my facial hair off. Should I do a mustache like this in real life?
Yeah.
You don't care. All right, everybody have a good
All right.